Thank you, and good afternoon, everyone, and many thanks to the organisers for inviting me to give this talk today. So I've been asked, as was just stated, to present a brief talk on targets and what lessons we can learn from control programs for some other infectious diseases. So I'm going to look at a little bit of the history, actually, of control efforts and targets for malaria, leprosy, and HIV, and then just reflect a bit on the lessons we can learn from these other infectious disease control efforts that might be relevant for TB. As was just stated, I think I was invited to give this talk mainly because my colleagues and I were invited by UNAIDS to prepare a background paper for a meeting they were holding in Lyon, Switzerland, last October. And this was about setting HIV targets and looking at the lessons that, again, looking at the lessons that could be learned from other disease control programs. So I've adapted that material a little bit so that it's of more relevance to this TB discussion today. Now, don't worry, this is not a slide that you're supposed to read. It's for you to look at, an eyeball. What we started by doing for that background paper was to look at the history of targets for these other infectious diseases, and that included HIV. And we prepared these diagrams which set out the targets at different time points, so from the 1980s in this case, going through to 2020 and after for each of these diseases. And the diagrams all look the same. They all had this same general pattern, which was one of ballooning targets. So in every case, we started with very few or usually no targets at all, going back 20, 30 years. And then over time, a ballooning with an ever-increasing number of targets, which were often confusing, overlapping, and in many cases inconsistent and conflicting. And I think that was one of the general messages we drew from this exercise. Let's start straight off with malaria, and I'm just going to briefly summarize the history here. And I'm going back to the mid-1950s here, as you can see, when the Global Malaria Eradication Program was announced by the World Health Assembly. And this really was aiming for global eradication of malaria. This was mainly using DDT, insecticide spraying for the malaria vectors. And indeed, this did succeed in eliminating malaria for some areas of the world, particularly areas of low endemicity and some island states, for example, where they were quite isolated. So there were some successes. But what was really clear from the start was that this would never work in sub-Saharan Africa. And in fact, it's interesting that the World Health Assembly, where this program was announced, there were no representatives from Africa, which seems in retrospect to be, absolutely appalling, but that was the case. By the late 1960s, it was clear that eradication was not going to be achieved, and the program was officially abandoned in 1969. And after that, there was a lot of disenchantment, and I think this illustrates the danger of having targets that cannot be achieved. And what we saw in the 70s and 80s was a massive resurgence of malaria and very few actions, actually, to try and, new actions to try and control malaria. And it wasn't really until the late 1990s when the Rollback Malaria Program really got off the ground that we again started to see some really effective target setting and planning to bring malaria under control. So I'm not going to go through all these targets, but I just wanted to pick out a few general points from this. So over time, there have been a lot of different targets and aims and visions and so on. These include targets for mortality reduction, for reduction in the number of cases. They also include process measures. So you can see, for example, the 2000, the Abuja Declaration. The target actually was not for a particular health outcome, but that 60% of those at risk would benefit from protective measures, whatever that means. So we have a range of targets. We have both process and outcome targets, and we have different sorts of health outcomes that are covered by that. In 2005, we had another declaration of an aim for malaria eradication, this time spearheaded by the Bill and Melinda Gates Foundation, recognizing that that was very much a long-term vision, probably going through to 2040 or 2050, and that it would require the development of new tools and techniques. So science was at the heart of that vision, really. And in 2015, at the bottom of the slide there, you'll see some of the most recent targets from the Rollback Malaria Partnership. So and I think I've got another slide here. So this is the Rollback Malaria targets for 2030. The goal is to reduce incidence and mortality rates globally by 90% or greater compared to 2015. There is still an elimination goal. The goal is to eliminate malaria from at least 35 countries, 8 of which, in fact, are in Africa, mostly in southern Africa, in the southern African cone, and to prevent re-establishment of malaria in all countries that are malaria-free. So what are some of the key lessons we've learned from malaria? Firstly, the malaria eradication program did galvanize support for a while, but it was unrealistic, and in the longer term it led to disenchantment and a resurgence in malaria. As I mentioned, Africa was excluded from the decision-making, even though it was the region that was by far the worst affected by malaria and continues to be so. The failure of that program led to, unfortunately, to reduced funding, also to de-skilling. So many of the teams and technical programs that had been developed for malaria control were lost, and then to a resurgence of malaria and subsequently an increase in drug resistance. The current strategy, which I think is much more realistic, is to combine elimination in some target countries of lower endemicity, but combined with continuing control efforts in highly endemic areas of Africa, and doing those two things in parallel. And we've also seen the importance of sustained commitment and combining horizontal and vertical components, so integrated services within primary health care, at the same time as maintaining a strong vertical program to ensure technical support. Moving on to leprosy, and I'll go through this a little bit more briefly. So this started not with an eradication aim, but with an elimination aim, and this was in 1991, again a World Health Assembly resolution here. And to their credit, they actually defined elimination in this case to be a prevalence of less than 1 in 10,000 globally by the year 2000. And actually that target was reached. So they reached that target globally, but at country level, all but 6 countries, in fact, reported reaching this target a little bit later by 2005. However, despite that global target being reached, transmission was not interrupted. And there was continuing high incidence of new cases at a subnational level in countries such as India and Brazil. The elimination target was officially abandoned in 2007, and since then, strategies have moved towards a focus on reducing the sequelae of leprosy, so grade 2 disabilities. And it was recognized that just focusing on new cases was ignoring the fact that there was a large clinical burden of people with grade 2 disabilities. So this is an interesting contrast with malaria. In this case, the elimination target was in fact realistic and was achieved, but in fact it didn't really solve the problem. And so it's important to define which health outcomes you're really trying to control and reduce, and to have strategies that will achieve that. This is a diagram just summarizing the current global leprosy strategy. They have a vision, which is all made up of zeros, as we often have these days. There's a goal, which is rather vague, actually, and then some specific indicators, as you can see there, for the year 2020. Some of the key lessons here from leprosy. The elimination target, again, galvanized support at international level, and it appeared to be effective at the global level, but this ignored ongoing transmission and the prevalence of disabling sequelae at a local level. As with malaria, when the elimination aim was abandoned, it was difficult then to sustain funding and the technical skills that were needed, and even research in the face of having achieved, apparently, this global elimination target. Even the main research journal for leprosy stopped being published around that time, which says a lot, I think. There were some other interesting findings. There were changing case definitions that skewed the interpretation of the trends, basically because of multi-drug leprosy shortening the period of leprosy treatment. That meant that the prevalence decreased just because the period during which you were measuring cases was decreased. And there were also some perverse incentives in case reporting, even some examples of countries not really looking for new cases because that would mess up their figures. And would not be seen as a positive achievement. Moving on briefly to HIV/AIDS, you saw from my balloon diagram just how many HIV targets there have been. And again, these have been of many different kinds. They include the Millennium Development Goal 6, which really didn't define what they meant by bringing these global infectious diseases under control, so they were very vague statements, really. There was the Political Declaration of Commitment in 2001, which had the first clear quantitative targets. And then there were a number of important process targets, like the 3x5 initiative, which was not about health outcomes, but about getting people onto ART. And of course, notably, these were successful in the long run. 3x5 was not quite achieved in time, but the 15x15 initiative was actually achieved in 2015, with 15 million people accessing ART by that time. We've again seen visions with lots of zeros, in this case 0 new infections, 0 AIDS deaths, and 0 discrimination, so a focus there on human rights issues, as we've seen for some of the other diseases. And then in the last few years, we've seen the launch of the famous 1990-90 targets. These are again process measures, but are assumed to be closely related to health outcomes and the incidence of new infections. And we've started in the last 2 or 3 years, following on from zeros, we've seen this new terminology of ending AIDS, as we've also heard about ending malaria and ending TB. Just a couple of diagrams here to emphasize the importance of complacency and the dangers of complacency. So in terms of the process target at the top there, we've done very well, really, in getting people onto ART, although there's still a long way to go. We're heading for the target, which is the red dot there, which is to have 30 million people on ART by the year 2020. That may well be achieved. But in the bottom slide, you can see for new HIV infections, really progress has been stalling, and we're nowhere near at the moment getting to that red dot at the bottom there. So key lessons from HIV: there's a real danger of complacency when some targets are met. There's always this tension, I think, between inspirational targets, which can really galvanize international support, but also a tension with what can be achieved in practice, and potential for disenchantment if those targets cannot be reached. So some difficult decisions to make in setting targets. I've mentioned before that we've got a lot of overlapping and, in fact, inconsistent targets, which can lead to confusion and also reporting overload in countries and fatigue, in fact, in sort of monitoring and reporting on all these different targets. As with leprosy, we've seen that a global advance may mask local failure, and we know with HIV that there are regions of the world where there's still a massive increase in incidence. So we must look at local pictures as well as global pictures. Something I feel very strongly about myself is the 1990-90 targets. It's going to be tough to get to these, but UNAIDS, just to remind you, says that by 2030 we need to get to 95, 95, 95. And I think that last 10% are going to be the hardest. It's going to be really difficult to get those last 10% into care and being effectively treated. We're also going to need additional tools, and that, I think, applies to other infections as well. And there's a real danger of funding running out as mortality declines. So just finally, to summarize what I think we've learned for TB, another diagram showing how difficult it's going to be to reach the targets. So the current global trend is a 1.5% reduction in new cases per year. We need to do much better than that to meet the TB targets. And I'm going to just show two final slides about what I think we've learned from those other infectious diseases for TB. So firstly, global targets can galvanize support, but they're not always relevant locally or in specific subgroups. That's something we need to think about. We need to make sure that we're involving a wide range of stakeholders. We mustn't repeat those failures, of not having African participants when we draw up targets. We must ensure equity. We need to consider outcome measures as well as process measures and consider all key health outcomes. And we need to avoid the confusion due to having numerous overlapping and inconsistent targets. And then finally, eradication or elimination campaigns must not be at the cost of control in high burden settings. We need to balance the vertical and the horizontal, so maintaining central technical expertise while integrating services into general health facilities, primary healthcare in particular. Targeting of reservoirs infection are going to be critical as we bring down the burden of infection and it becomes more concentrated, but we need to remember the dangers of stigmatization when we do that. We need to make sure we have measurable targets, and we need to invest in data collection so that we can really effectively measure progress against those targets. We need to sustain funding when incidence is declining. We need a continued investment in research to develop new tools that are going to be needed to achieve these targets. And finally, I think we need to remember these three key activities that are pivotal in making sure we reach targets. So science and research to ensure that we develop the new tools we will need, and then the delivery to make sure we can effectively deliver services, especially when we have those new tools. And finally, not to forget that many of the improvements we've seen in TB, leprosy, and other infectious diseases have been as a result of general social and economic progress, so we mustn't neglect that. Lastly, I just want to acknowledge my co-authors on the UNAIDS paper, who are all listed here, and to UNAIDS for funding the work that we did on that background paper. Thanks very much.
Thanks.